In today's cost-conscious environment, there is no question that less invasive surgery and certainly single position surgery has made our hospital administrators very happy. I can now perform a single level XLIF with perk screws in under an hour. Even with the ridiculous turnover times at Stanford, I can perform 3 or more of these in a day. With newer multimodal anesthesia and erector spinae plain blocks, the majority of these patients can go home within 23 hours. All these factors increase productivity, reduce OR consumption of PPE, and really enables more surgeries to be performed in an ASC setting. It's really a win-win situation.
Yeah, so I think in terms of taking this minimally invasive procedure, with the added sort of steps and cost, by doing these less invasive procedures, the pain is less. Patients are up and moving quicker, and other sort of secondary issues like blood loss. We're not having big blood loss issues and fluid shifts with these procedures because of how minimally invasive they are. And because we're not having a lot of bleeding, we're working through these planes that don't bleed a lot. It means also that we can move quicker and the OR times are a lot less. So the savings comes in multiple steps. Number one, the cases are shorter, so the OR time is less. Patients are up and moving quicker. They're out of the hospital quicker, and their requirement for pain medication, narcotics, tends to be less, or how should I say, lower doses initially, and then we're carrying the narcotics. They're coming off of their narcotics a whole lot quicker. And I think the other way to look at the value of this is because we can get the cases done quicker, that means we can get more cases done in a given day, which then is beneficial both to the patients. Their wait time for surgery is less. It's beneficial to us. We can take care of more patients, beneficial to the hospital in that they have more throughput in a given period of time. So I think these less invasive procedures, although maybe superficially or at front may cost a bit more, I think the savings is really substantial on the back end.
The head of our OR, who, he's been a vascular surgeon in our institution for years, and our head orthopedic and spine and neurosurgery nurse, they're kind of shocked how cost. I'm very strict on cost. And, when I first said, hey, I'm going to be doing these XLIF, ALIFs, and I showed them the price of the cages and of the disposables and, more neuromonitoring, those sorts of things, they were like, whoa, why can't you just use screws and rods? In fact, they're like, no, please do this. Please do the open stuff. We don't want to pay for all these things. And then once you get into the data, you're like, listen, I get it, but here's the results. People are going to be leaving the hospital, post-op day one, every day in the hospital, every hour in the OR, that has costs, and that's real. Not to mention the downstream costs of infection risks and those in reoperation and those sorts of things. Again, I mentioned the, us being in the Midwest, I can tell you, probably, I'm not sure how many surgeons in my area are truly measuring pelvic incidence lumbar lordosis, which in my opinion, and probably for most people who are listening to this, if not all, that's standard of care, right? We all know that Roth and Flu study that has been duplicated many times. That we know you got to restore that within 10 degrees. And then of course, A's match as we get older. Otherwise the chance of reoperation is significantly higher. And I think the way to achieve that is using the stuff that costs a little bit more. So XLIF, ALIF, planning out facet resections, those sorts of things. So one of the newer things that I've kind of dove into, which, is certainly prevalent around the country, is that of, single position lateral surgery, whether it be, XLIF, whether it be ALIF, or a combination of the two. And that's something that's huge, right? So a lot of people kind of calculate in their mind, okay, by the time we flip, put them in, I'll save 30 minutes, that's it. But it's actually a lot more than that because, I can put in screws while the vascular surgeon is exposing, my nurse practitioner can close the XLIF wound while I'm doing the screws and all these sorts of things. And so a lot of this time is really doubled up. and that can have tremendous value for the patient. One of the things that doesn't get talked a lot about, especially, you know, being an orthopedic guy by training, is that of, you know, the most common issue that you should be wary of after ALIF, XLIF is that of ileus, or kind of bowel function. And when people are in the lateral position, that certainly is much more improved compared to the traditional supine ALIF, which has kind of, you know, expedited or helped out with our most folks going home post-op day number 1, which for a multi-level lumbar fusion, I mean, that's huge, right? Because, you know, all through training, residency, fellowship, you know, multi-level lumbar fusion, I mean, you're in for 2 days just for the drain alone, if not 3. And then rehab and all those downstream costs. And so, yeah, these people are going home too. They're not going to rehab or skilled nursing facilities. And so that's something that I think really surgeons should take a look and say, hey, you know, what am I doing and can I do it better? And not only that, but not just for your benefit, for the patient's benefit. So, yeah.
I'm going to talk to you about the movement toward the ASC. And I think there's primary drivers, and there's certainly, you know, some criticisms associated with it. Obviously, I think one is most surgeons like to operate at an ASC because it's more efficient. They're more in tune to what you need. Usually the ASCs are very specialized to the procedures. So where a hospital, you know, is, you know, they'll do 30 procedures, the wide breadth of procedures, all the way from general surgery to OB-GYN to prostate disease to tumor colon surgery, and then spine and orthopedics. At an ASC, you're not going to see that breadth. So an ASC is specifically designed typically for 5 to 10 procedures. And because of that, they're in tune with what you're doing. And so the environment is always better. People are always happier. And, you know, it's just a very good environment to work in. So I think surgeon preference to work in an ASC, you know, it's going to happen. And we're going to see more surgeons evolve toward an ASC type of environment. Now, on the patient side, what's allowed that is certainly less invasive surgery. When you're talking about spine surgery, you know, I think it'd be very hard 15 years ago to even imagine a posterior fusion surgery being done in an ASC environment, you know, where I think that that's changed dramatically. Even to the point where, you know, you're seeing a lot of anterior lumbar surgery being done at an ASC environment. And I think that's just the natural progression, because as surgeries become less invasive, as we are able to deal with patients better as far as their postoperative pain and their expectations, we are seeing that we're moving these to an ASC. The financial side of it makes complete sense because many of the ASCs are partly owned by the physician, and that is a great secondary income source, as well as the fact that we know that ASCs are cheaper than a main hospital. So on a healthcare perspective, on a healthcare economic perspective, you know, there is a push from everybody besides probably your major hospital if they don't have an ASC. When you look at the primary payers, Medicare, Blue Cross, Blue Shield, they all want to promote the ASC because they know that most likely the quality of care is just as good, if not better, and their cost is probably about 50% less. So I think all those factors, you know, together are pushing cases toward the ASC. I think what's most important is that it's good counseling to the patient. It's the expectations that you need to talk to your patient. It's about great patient selection. You know, not every case should go to an ASC. So, you know, that takes a little bit of experience. You know, in the beginning, you're very cautious. You may only do microdisc. You may only do one-level cervical disc replacements or ACDFs. And then, you know, as you get more comfortable and you get some history and some experience, you start expanding those cases. So, you know, in Southern California, in my territory, where we've been doing ALIFs at an ASC for probably over 12 to 15 years, you know, and you know, doing an ALIF at an ASC, which in some areas they would probably think is absolutely crazy, is quite common. And the reason is because at 5'1", right, we have amazing vascular surgeon who's probably done 6,000 cases, who knows how to do this. And, you know, we can do it. We don't do, you know, BMIs of 30s, right? The other issue is an XLIF. If you're doing an ALIF, you know, at L5 or above, obviously doing an XLIF at ASC is completely reasonable if you're very comfortable and you've done many. So I think, you know, there are procedures that have enabled us to go over to the ASC. I think if you said, hey, we're going to do a, you know, posterior lateral fusion, whether that's one level, and you want to expose the gutters, that I think that's challenging due to post-op pain control and the amount of oozing that you would have. And so, you know, I think for those, you know, posterior, you know, mass midline approach where you're not going past the lateral borders of the facet, you're getting posterior fusion, whether it's from the lamina or an inner body. Obviously, I think those can be done in the ASC quite effectively.